15 bowel movements a day. I said, are they liquidly and they smell bad? And she said, oh yes, they're just god-awful. So I said, okay, I have something that can help you. So I did the exam, and she was very malnourished, very cachectic, cramping, noise, borborygmi, and we put her on pancreatic enzyme replacement. And what was interesting is I asked her, has your doctor ever put you on this? Well, she said, oh, we've tried 3 different kinds. He says, I'm allergic to them. I said, well, you really can't be allergic to pancreatic enzymes. How is he giving you them? Oh, he says I have to take them in plenty of time before the food, that I should take them at least 20 minutes before I have the food. I said, that's why you're allergic to them. Because what's happening is you have to give it with the food. All it's doing is kind of working on your stomach. It has to have the food there. So within 3 days of actually starting her on an enzyme, explaining how to use it, she went from 15 minimum liquid malodorous stools to 3 a day. Now every once in a while she'd still have a little bit of a problem, and I said, well, let's have a diary. And she would figured out that it was also with juice after her stomach had been reconstructed, that she was actually having a little dumping. So it was a different kind of diarrhea, but we figured out what it was. This woman, we actually figured out now, we said a pancrease enzyme for every 5 grams of fat. So she could know how much was fat, how much she should be taking in, so she could actually, rather than say, oh, just take 5 or 6 a day, with each meal. What's interesting is she can now have a Big Mac or fast food and have no problems, because she learned how to do that well. She's still got the same pancreatic insufficiency, but she knows how to treat it. What I'd like to have you do is think of the patients that you know of with pancreatic cancer, who when the first time you met them weighed 38 kilograms, and what they look like 6 or 8 months later. You have an image in your mind? Is that it? Probably not. When I first met her, she was dependent in her activities of daily living. She was on disability. She actually looking like this. This is when she went to see her son's wedding. It was 6 months later. That was the thing that was keeping her going. And she actually, after I followed her for another 3 years, she went up to 53 kilograms. She was working full time. She had no evidence of disease. This is a woman who I guarantee would have died of her malnutrition. She had the good kind of pancreatic cancer, and it would have been a shame to have her die of malnutrition and not her disease. So how do we go from my experience to something that actually is able to help people across the world at this point? What's interesting is that Drs. Gigi Boydetsky and Baker in the early 1980s talked about something that they called the subjective global assessment. Now they talked about it for a number of years, but never showed anybody what it looked like, so it was really very hard to know what they were doing. In 1987, they actually published it as a usable format, and that's very fortuitous because in 1987 I was doing my surgical oncology fellowship. And when I read this, I thought, I like this. It's a great backbone for what I want to do. Why reinvent the wheel? Because they had a lot of data. But I talked with them and said, I'd like to do something that's more patient-generated, so that we're actually, in oncology, this was out of surgery. In oncology, a lot of people don't really appreciate the importance of nutrition. So what I'd like to have is that the patient actually fills out some of this information. And I'd also like to give a little more information that will help us above and beyond some of the things you have here. And they were actually very, very supportive of that. And I subsequently started a nonprofit research and education group, and Dr. Gigi Boy, who many of you may have heard of, was an important part of helping us with that. So in 1994 was when I first came up, the things that are in orange, and of course you can see I have orange here and all of my slides are orange. That's because recently I became visiting professor at the Hansa University in the Netherlands, and orange is the color of Netherlands. So that's why a lot of these things you will see that connection. But basically what I did is added the 3 months and the 1 month to the questions they were asking. I also included some additional symptoms, subsequently to include even more. and a few other minor changes of it. But this was, I thought, at least the beginning stages. So that's what we did in 1994. Now, based on that initial work, and when I talk here about standardized nutritional assessment, that was the first version of the PG-SGA, and it wasn't scored, and it looked a bit like the one that I showed you on the previous slide. Now, there's a place called the Fox Chase Cancer Center in Philadelphia, which is where I was doing originally my surgical oncology training, and then subsequently became on staff, and actually naively volunteered to do all of the inpatient and outpatient parenteral nutrition and enteral nutrition. So I got lots of experience with nutrition there. We looked at 186 consecutive patients who were referred to the nutrition clinic. The average weight loss at the time of referral was almost 17%. So clearly this was not early intervention. I will say that some of them came from other places where nutrition was not such an important part, but some of them also came from our institution. And why were they so badly malnourished when they came to see us? Sometimes we just had a physician who didn't think of it proactively, but I think sometimes they also realized that there was nothing else they could do for the patient because of chemotherapy or radiation therapy. They'd gone to the end of the road of their cancer treatment. And what was interesting is the family would say, or the patient would say, "You mean there's nothing else you can do that will help me?" Well, we have this clinic. It's a nutrition clinic. It's run by this really interesting woman, Dr. Ottery, and she may be able to help you with some ideas. So we get them in, and what was interesting is, one, it gave them hope that there was still something that could help them, but more importantly, because of this interdisciplinary intervention that we included with the standardized nutritional assessment, very aggressive symptom management. So if I saw somebody who was having nausea, vomiting, constipation, diarrhea, even though I wasn't their medical oncologist and they were going to be treated continued with their oncologist, I would write them a prescription that day. They didn't have to wait a week to have their symptoms taken care of. So aggressive symptom management, individual nutritionalized counseling, oral nutritional management, and exercise recommendations or physical therapy consult for every single one of those individuals. We did the exercise bands so that anybody could do that. They could be watching TV. I had one man with pancreatic cancer, strangely, who was an investigator, a detective, and his son lived in my housing complex, and he said, "Oh, Dad, when you're on the steakhouse looking for the people," he said, "you could be sitting in the car doing your exercise." Well, I think that would be a little obvious, but the thing is you can do them anywhere, and that works.